Okay, now we're going to talk about the part of perioperative nursing care. We're talking about the intraoperative period. Okay, so the intraoperative period starts at the moment that the patient enters the operating room until the patient is admitted into the post anesthesia care unit. Sometimes it is used interchangeably as the recovery unit or the recovery room. So if you hear me say recovery room or PACU or post anesthesia care unit, those are all used pretty interchangeably, and in terms. Sometimes you'll hear one unit or one facility will say the recovery room or PECU. So they really mean the same thing. It's just different terms, depending on how the facilities like to call it that. So the members of the surgical team, there is always, of course, a surgeon involved, because how do you have a surgery without a surgeon? There is either an anesthesiologist, or there is a nurse anesthetist, which is a certified registered nurse anesthetist, or CRNA. You will have a scrub nurse or a scrub tech. They are specialized train. They receive specialized training. Typically, they are not actually a registered nurse or a nurse. Sometimes though they are a registered nurse or an LPN that has had a different level of training to become a scrub nurse for that, but typically they are a different. They have been trained differently, so they are a scrub tech or scrub nurse, so they have a different level of training. And then you have a circulating nurse. That is typically what you see with registered nurses. That is the main job that we will talk about, is the circulating nurse, because you will have a circulating nurse in every OR. And then you will often have as well a registered nurse first assistant, which is kind of a specialized trained registered nurse that is kind of the first assistant to the surgeon, that does some kind of specialized care and procedures with the surgeon, such as suturing and different types of techniques and procedures as well. They are scrubbed in and part of the procedure, while the circulating nurse is not scrubbed in. So typically the circulating nurse, the anesthesiologist are not scrubbed in, and most of the other team is scrubbed in. So the guidelines for surgical asepsis. So within the sterile field, everything must be sterile. So the gowns are sterile in front from the chest level of the sterile field. The sleeves are sterile from 2 inches above the elbow to the cuff. Only the top of the draped tables are considered sterile. So underneath that level of the tables, even though they're draped, those draped areas below those are not actually sterile. So just the top of those tables are considered steriles. Items are dispensed to people within the sterile fields to preserve sterility. So the circulators are not sterile, but if they need to dispense something to those within the sterile field, they will dispense them in order to preserve the sterility. So they are dispensed in a way so that obviously we're not going to touch them in any way, and we will dispense them onto the sterile field so that we do not pass over the sterile field in any way. And then they do not touch we do not touch any area of the sterile field in any way. The movement of the surgical team are from sterile to sterile and unsterile to unsterile only. So we do not move into the sterile field. They do not move into the unsterile areas. So the only time that there's interaction is if we are moving toward the sterile field to hand them equipment, and it is only at the point that we are moving, it's bringing supplies, and it's only to the point to bring it, and we're moving it in an aseptic technique. So we're moving it into the sterile field in a way to not break sterile. So we have different responsibilities in there. So the scrub nurse does have responsibilities, and like I said, it is typically a surgical tech that has that specialized training, but I have seen RNs and LPNs that have done scrub nurse responsibilities with different training or additional training added onto it. So they are going to work within, and they are they must maintain the integrity of the sterile field. And they must maintain the integrity of the OR environment. They protect the healthcare team members from exposure in blood and other bodily fluids. So some of the specific duties that would include is they will work with the circulator nurse to count the, they will do the counts before and after the procedure, well, not before and after. So they will do the before counting. So they set up the sterile equipment, and they will do the counts with the circulator before the procedure starts, and before the closure of any incisions, they will do the counts as well, because we need to make sure that nothing is left inside of the body cavities. They will be responsible for making sure that all of the equipment is prepared and ready for the physician. They're responsible for handing the physician all of the equipment during the procedure. They will be responsible for like suction. They will be responsible for making sure that like they'll do things like what I want to say. I can't remember the name of what I'm trying to say, but like they'll hold open like wounds and things like that. They'll suction during, they'll do retractors and things like that. They will ask for equipment. They will work with the circulator to get the sterile equipment from the circulator as needed. They will ask for like any other sponges or anything like that. Anytime anything is added to the field, they will add it to the count. They will get sutures, anything like that prepared and ready as well. Okay, so the circulating nurse's responsibilities, and I'm sure this documentation piece might be somewhere else, but I just want to make sure I put this at the beginning, and I'll say it probably multiple times throughout. But one of the very, 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 very important pieces of a circulating nurse's responsibilities is documentation. Because you, as a circulating nurse, will be the person that is not sterile. You will be the person that is able to write things down or type it into the computer while everyone else is sterile. So you can document everything that is happening while in the OR. So first of all, the nurse kind of continues the preoperative stuff, and you're checking all the things in the chart that needed to be done before you get into the OR, and then you're kind of checking it also while you're in the OR. But the circulating nurse must be at least an RN, a registered nurse. You will be the person providing emotional support to the patient from that holding area till when they're going into the OR, and while they're getting into the to the operating room table, and while you're getting in there, you're being a patient advocate. You're providing them as much privacy as possible, and as the patient is sedated and unable to be their own advocate, you're being the advocate for them. So you're making sure you maintain their dignity for them in the OR. So you're their advocate at that point. You're also, and this is done really before they get into the OR, you're checking all that equipment for malfunction before that surgery happens. You know, if they need a scope, you're making sure the cameras work. You're checking the gas on the laparoscopic surgeries, because that kind of inflates their abdomen so that you can get the scopes in and get the procedures in so that you can see very well in there. So you don't want to get in there and that not function. You know, all the different equipment that you need, making sure that everything is available and ready before you get in there, because otherwise you're in there, a patient's sedated, and you don't have what you need working. That's not good for anyone, and that would be, you didn't do your job well. He would position the patient for the surgical procedure, or provides the patient safety. So part of that is, you know, keep side rails up, you're at their side. Anytime the side rails are down, you position the patient for the surgical procedure. And this is really dependent on the procedure themselves. Obviously, if you're working on their abdomen, they're going to be on their back. If you're working on something like a pilonidal cyst, which would be around their coccyx area, you would have to put them on their abdomen. So there's a lot of different positioning that would be involved. If you were working on hemorrhoids, you would have to put them up in like a lithotomy position. So depending on whatever kind of procedure that they're having, that's your job, and you're working with, and you're going to have assistance with that at that point, but you're going to be working with the team to help with the procedure. But ultimately, it's your responsibility to safely get them positioned for the procedure. And then once you get them in the position, you get them safely positioned, get them off of spots that would be, you know, causing any kind of like neurological damage. You want to make sure that they're off their pressure points, and get them as, you know, as comfortable as possible for a patient that's going to be completely sedated, and as safe as possible, to a point where you're not going to have a patient that could fall off the table, right? And safe. You're going to also then do the next step. So do they need a Foley? Do they need SCDs in place? Which most of your patients having any kind of prolonged surgical procedure are going to need like an SCD, because we don't want that blood to pool in their legs. A lot of them will need Foleys, but we only do that if it's a prolonged surgical procedure. If it's short, we do not put a Foley in place. Most of them come in with IVs. Usually if it's an IV that we place afterwards, it's because it's like a pediatric patient. But sometimes we may put in another IV for a reason. So you may need to place an IV, you may need to place other kind of tubes, an NG, something like that. So you may be placing other kinds of tubes, equipment, something in the OR. You're going to do a prep of the site. Typically, we use a DuraPrep for abdominal surgeries. We may use iodine prep for something like a hemorrhoids, or, you know, there's other kinds of things that we'll use depending on what we're using. You're going to prep the site for it. So that will be the circulator's job, to prep the site with the prep, and to do that using the proper technique and make sure that that is dry. You will not be the draper, because that is for the scrub tech to do the drapes. You will collaborate with all of the other team members of the surgical team to ensure that the correct placement of the anesthesia and the monitoring equipment is done. You will provide the supplies, the equipment, and the medication to the team as needed. So the surgical scrub tech, they come in prior and they kind of set up that sterile field. And I think this is on the next slide, that, you know, we're gonna be the ones that do that initial count with the scrub tech, and we'll do the post count. We'll talk about that. But during the surgery, there's equipment that cannot be provided until certain times that we don't know when we're going to need it or if we're going to need it, and we'll provide that during the surgery, or we can't provide it because there's only certain ways we can provide it and keep it sterile, etc. So we have to provide it in certain ways to keep it sterile, but because we're the non-sterile, we have to provide it that way. And then it is our job as the circulator nurse that we are basically watching the sterile people as like a hawk. And we will literally have to stop and call the surgeons, and the surgeons have no right to argue with us. If we say they're not sterile, they're not sterile. They do not have the right to argue with us. If we say your hand touched something, they don't get to argue. If they think it touched, if they don't think it touched, there's no point in it. And I have called up surgeons multiple times, and I said, you have to add a glove, or, you know, your glove touched something, you're not sterile any longer, you have to move it. And it really does not matter how big or small the sterile break is. Once that sterile break happens, they're no longer sterile, they have to fix it. So we always have, like, you know, the sterile techniques or the sterile breaks, we have the policies in place for what to do. So like if a sterile glove, for example, with the surgeon, if their sterile glove were to touch something, typically what were to happen is they would take another sterile glove and they would cover over that. If they're sterile gown, sometimes they can take another sterile gown and cover over that. If it was a large, like if their glove were to get cut, they would have to go and re-scrub. So there's always a policy in place for what they would have to do. But the circulating nurse, it is 100%. Like no matter what they say, if they catch it, they call it, and it is a job to watch multiple people like a hawk the whole time. Luckily, if you get a trained crew, and the good news is, I mean, everything's sterile in front of them, so it's very hard for them to break sterile as well. But if you get a very good trained crew, they're usually not going to break sterile after a while. Okay, so also the circulating nurse will monitor intake and output and blood loss. Once again, they're documenting. So all of this goes on that documentation, and they are the people that record this and needs to go in. And they will count all the gauze, the gauze sponges, the sharps, and all of the instruments have to be counted with the scrub nurses before the incision closure. So they counted it prior to the surgery, and then they have to do that count before that incision closure. So the surgeon sometimes will kind of try to jump the gun, and you have to stop them. You have to say, stop, 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 stop. You have to stop them. They cannot start closing. You will have to stop them and then get that count started. And it is really important. And you will see, like if you ever start working in an OR, you will see that surgeons they just kind of get into auto mode, and you'll have to stop them. You will see that sometimes the gauzes will be kind of left on the field. Most of the time it's not left in the patients, but sometimes I have actually caught surgeons leaving them in the patients when you are counting, and it's a good thing that you stop them. So it has happened hundreds of times, and that's the reason why they always get counted. Also, you are the person that is responsible for transporting all specimens. So now there are times where specimens need to be moved in and out during procedures. So really the most of the time that this is happening, if you're taking off like a cancerous specimen and you're wanting to make sure you get margins, you'll usually have a runner to do this if this happens. So they'll go in and out during the procedure. But most of the time what happens is you're taking them during the procedure and you give them off at the end, but you're also documenting all the procedures, you're handling, you're labeling them, and at the end you'll be the one responsible for transporting them to a pathology or lab wherever they go to. You'll be assisting anesthesiology with the transfer of the patient to the PACU at the end, and you'll be the person reporting to PACU nurse at the end. Now, before I talk about the information report, I realized that I did not talk about the timeout on either of these two slides, and that's really important. So I do want to say that timeout is not solely the responsibility of the circulating nurse, and I may talk about this later, but I want to talk about it because the circulating nurse is the person who documents timeout and who typically ends up being the person who does the timeout for the OR just because they document it. So before any operation starts, there is what is known as a timeout, and what happens is somebody says, and anybody can call the timeout. It can be the scrub tech, it could be the anesthesiologist, or the nurse anesthetist. They can call it. It could be the surgeon. It could be literally anyone who is involved in the surgery. But what they will say is, stop, we need a timeout. And all that means is you need to make sure that it is the right patient, it is the right surgery, and it is the right site. And then everybody agrees, and then they need to check it against the consent, which the circulator nurse is the person who has the consent in the chart. They check it against the consent and everybody agrees, and then they can proceed with the surgery. So once they agree, the surgery continues. And that is just really important that you know that. So now I'm going to go back to the nursing report in the PACU. So what information is included in the report? So first of all, you're going to let the PACU nurse know what was the surgery, how did the surgery go, time in, time out, what kind of fluids, estimated blood loss, what medications the patient received, last pain medications, last set of vitals. any kind of comorbidities that the patient has, risk factors, and anything that is important to know that could be important to know about their, well, it's really kind of risk factors again. Important to know that could be a risk factor, such as like respiratory cardiovascular history, or something that could affect the recovery. So kind of going back now to the different types of anesthesia, because this is really important for you to know as well. So first of all, general anesthesia. So when you think about surgery, this is kind of the anesthesia that you're probably thinking about. So this is used for major surgery. So anytime you have a surgery where a patient is intubated, they're under a general anesthesia. So this is either given as an IV or an inhalation anesthetic agent, and it causes the patient to lose sensation and consciousness. The moderate sedation is going to be used for minor surgeries, or procedures that are like uncomfortable or painful diagnosis procedures. So this would be stuff like if somebody was having a scope, like a colonoscopy or an EGD, or sometimes if patients are like, they will even give this for patients that have like claustrophobia for like MRIs, they'll give them conscious sedation sometimes, or moderate sedation. Sometimes they call it conscious sedation. They give this for dental procedures as well. This is given as IV sedation and or analgesic medications as well. And it just makes the patient depressed level of consciousness. So it doesn't really cause them to not be able to breathe on their own. It causes them to become drowsy and lethargic, but they're still able to breathe on their own. And if you were to talk to them, they would be able to respond, but it's more slowly, and they have a very decreased response to you. Okay, so there is regional anesthetic, which if given, you lose the sensation in an area. So the patient is actually completely awake during regional anesthetic, unless it's combined with a general or conscious sedation, which it can be. But if you're given just a regional anesthetic, the patient is completely awake. So they're awake, but they lose that sensation. So they don't have feeling where the incision is. Now, this can be given spinal or epidural. So if it's given in spinal anesthesia, it's actually given in the subarachnoid space via lumbar puncture. And then what happens is that blocks movement and sensation below the level of the injection. So then the patient would not have feeling below that level. And so if an incision was to happen, they would not have that sensation, and then you could work on that patient below that level. If it was an epidural anesthesia, it was given in the epidural space, and it would just block that sensation as well. You could give more of that anesthesia, more regional anesthesia continued. You would have local anesthesia. You could just give it, just inject that into a very specific area where you're just blocking that local, those local nerve sensations, so that we would block that local area of sensation, work on that local area. You could also do a nerve block where you inject that around a group of nerves to block the group of nerves, so we would block a larger area. And then you could also just do topical anesthesia where you apply it to the surface of the skin. So it's not really like blocking as much of the area, but it numbs the area more on the surface of the skin. So that would be something like if you think of like Oragel, how that numbs the mucous membrane, if you would put that on top of it. So it does block some of the sensation, and it decreases the sensation of pain in that area. Oh, there's the timeout. I thought it was on here somewhere. So I've already talked about this somewhere. So the purpose of it, so that you don't have a wrong person, wrong procedure, or the wrong site surgical areas. This has been implemented for years, but the reason why it was implemented is because this was an issue that was happening. People were getting the wrong limb taken off. They were, at one point, um, this was an issue. So this has been implemented. It has been a safety check that has been found to have improved this error. So having a timeout in the OR is just another safety check that has anyone in the surgical team, they call out timeout. Everybody must agree, name, procedure, surgical site. You also look at it against the consent, and once everyone agrees, you can move on and continue with the surgery. I kind of touched on this earlier as well. This is another one of those jobs that really is the circulator's responsibility. She does work with others, but it's really ultimately her job to help with the positioning. Of course, you want them as comfortable as possible, making sure that you have the field adequately exposed. You're setting them up so that they're set up for the procedure in the correct way, and making sure that you're not obstructing respirations, you're not obstructing any kind of circulation. You don't have them like on any pressure points in any way that you're really going to cause any kind of nerve damage or anything like that. Older adults, obese patients, extra thin patients who have what I would say, like bony prominences, or anyone with a physical deformity, you may have to do like extra padding, pillows, things like that. You may have to take extra precautions with them as well. Okay, so some patients are going to be at a higher risk for hypoxemia than others. One of the most important things is if you have a patient that's going into the OR that hasn't been in PO, and this is going to happen most often with patients that are emergency surgeries, it's really important to pass that on to the anesthesiologist. And most of the times what happens is we put them in with an NG tube so that we're able to suction that out so that we're not going to be at risk for vomiting, which is caused because of that loss of reflex due to the anesthesia. You put a patient in, they're NPO, we paralyze their GI system, we put them on anesthesia, and that's what can happen. So that's that nursing care for that, and we're going to watch them very closely. We're positioning them really supine. There's really not, the position that's going to allow for expanding their lungs is going to be able to raise them up. But really, we have to, most of the time, we're going to have these patients in supine positioning. So, it's good to know what we have going into that. And so it's just really that communication with anesthesiologists so that they're aware of what's going on. And so it's going in with that information and just being aware of that going on. And typically, as long as we're able to monitor and suction and NG and have that available, we can usually prevent that complication, but they still are going to be at increased risk for that aspiration, even with the NG tube. But usually we can decrease their risk with an NG suction, NG to suction in place. Now, hypothermia, we're going to have patients that are going to be increased risk for hypothermia over others, especially elderly patients, and especially those with have decreased subcutaneous fat. They're going to be at increased risks of heat loss. Now, you can't put extra clothing on a patient in the OR because we need to be able to get to their bodies as needed because they are a surgical patient. But what we can do is we can put a heated blanket on them, a warm blanket on them, or we can put the electronic warming blanket on them as needed. And that is really mostly what we would do for them. And we just want to monitor their temperature frequently. And typically the anesthesiologist will keep a temperature strip on them and monitor that very closely as well. Okay, so one of the complications I want you to know about is malignant hyperthermia. Now, it is not a common complication, but the problem is it is a severe and potentially deadly complication. And once it happens, it needs to be treated immediately or it can cause death. So if it happens during surgery itself, it can be, you need to catch it immediately. And so it can be kind of subtle from the circulator's eyes. And so I'm going to tell you what to watch for. So what happens is some patients just kind of have this rare autosomal dominant trait where when they are exposed to certain anesthetics, they will, when they process it, they start having this reaction to it and they begin to metabolize it in a way that their body starts having this hyperthermic reaction. And so they have this rapid increase in heart rate, respiratory rate, and then as it continues, it progresses to hyperthermia and dysrhythmias. As also what happens is they also have muscle spasms and rigidity as well. So in the operating room, one of the first signs that you will notice, and this is not on here, so you need to pay attention to the lecture. So you need to notice muscle rigidity or stiffness or spasms occurring in the operating room, because you may not know that they're having a rapid respiratory rate, right? Because they're ventilated. They may have an increase in heart rate, but that could have been pain or them waking up or something else, right? And if they're having hyperthermia or dysrhythmias, that's later on. So we need to catch rigidity or stiffness, because that shouldn't be happening in a surgical patient at all. And if we see that, that is a sign that they are reacting to anesthetics and they're having a malignant hyperthermic reaction, and it needs to be noticed immediately. So if you see a patient having signs of like stiffness or spasms, that is a signal of malignant hyperthermia. So if you ever see that, you need to call that out and it needs to be checked immediately. And we need to say, hey, I'm seeing signals of malignant hyperthermia, and that's an immediate signal of malignant hyperthermia. So if I'm saying, hey, what's a sign in the OR of malignant hyperthermia that you should catch and immediately call out? That is like spasm, stiffness, or rigidity. That I want you to know that. Now you can know the other symptoms. The rapid increase in heart and respiratory rate is important to know, but you must know that you should catch that stiffness, spasms, rigidity. And then the other stuff that once you progress to that hyperthermia, so that in that major hyperthermia and dysrhythmias is later in the stage as well. And there is medications for it. You don't need to know the medication. There's treatments for it. By the way, it's like super expensive, and they usually keep like 1 or 2 kits on hand per facility at a time. Sometimes it's going to be bigger for larger facilities though. Also, paresthesias. Remember we talked about positioning patients to keep them off those nerves. So patients can have numbness, prickling, stinging, or burning because of those nerve injuries. So really, to prevent that, we want to make sure that we try to keep them off of those areas where we can get those nerve injuries. Pressure injuries, if we keep them on the same area where they can have tissue compression from that immobility during surgery, then we can cause pressure injuries. And really the nursing care for that is to try to keep them off those areas that are going to be very high pressure, and then padding and just whatever we can do to try to keep them off of that. So patients, of course, they're having surgery, and during that we're looking at the blood loss for that. So that can be caused by either an internal or an external bleeding, fluid loss, or inadequate fluid intake. So the nursing care for that during the surgery itself, obviously we're not in there cutting into them, hemorrhage, hypovolemic shock. We can't prevent anything that's happening during the surgery, but our nursing care is really to monitor that, remember, circulator, we're monitoring that, we're taking that down, we're documenting that, we're watching those sponges. So our nursing care is to be notifying the physician once we're like, hey, this is a lot, we're seeing a lot of blood loss, we're on like 20 we have 20 soaked sponges. We're at this level. So we'll be monitoring that and notifying the physician once we get to the point. And then anesthesia's got the blood pressure. So we'll be discussing it with them, like, are we seeing any drops in our blood pressure? And so if we need to, we may be calling, we may be having to call lab back there. We may have to get lab. We may have to type and cross. If we have blood, that might be something that we'll be ordering and getting brought back. Now, we're typically not the people that are actually giving blood during the procedure. That will be anesthesia as well. Which, by the way, it's not bad when we're not the ones doing it, but we'll still be documenting all of these things that are happening, and we'll be the ones calling and organizing and collaborating with all of the care team. So there, of course, we're giving these patients anesthesia during the surgery, and there's going to be all these things involved. And when you think about anesthesia, we're putting people literally to sleep. We're taking them and we're sedating them to the point where they can't breathe. So there's going to be some problems that we have. With all medications, we run the risk with allergic reactions. So you're going to look for the signs and symptoms of allergic reactions that you can see with all medications, where you're looking for hives, flushes. When a patient is intubated, you're not going to be able to see the respiratory symptoms quite as much, but as they wake up, you would be able to identify any wheezing, or abnormal respirations, problems breathing, like that. However, if they were not fully sedated to the point of intubation, you would be able to identify abnormal lung sounds as well. You can identify any kind of like drug reactions. A lot of anesthesia causes nausea. That is a very, very, very common reaction. It is important to note if a patient has a history of that, and just to kind of like bring that up with the care team, because of the anesthesia causing that immobility. Because the patient, everything just kind of sits there, they do have that risk of thrombosis. And like I said, most of the time, if a patient, the circulator will most of the time be putting SCDs on our patients if they have a long surgery at all. If they're going to be fully sedated and intubated, they most likely will have SCDs during the procedure to help decrease that risk of thrombosis, because we do not want blood to sit and coagulate. Because of anesthesia, CNS changes can occur. Oversedation is really the most common problem with that. Is that it's just going to take them a lot longer to wake up, and especially elderly patient, because it takes them longer to metabolize their medication, because they have that slower metabolism. Often they'll be in recovery for a longer extended period of time. Under sedation can happen. You will hear stories of anesthesia awareness. It doesn't happen as frequently. Most of your anesthetists and anesthesiologists are very well trained, where they are able to identify signs of a patient's anxiety or stress if they were to start maybe to wake up and feel any kind of discomfort. So they would be able to identify any signs of that. But there have been stories of that in the past. Trauma during surgery can occur. And like I said, patients will wake up and they will feel a very sore throat from the ET tube, but there can be some extended trauma from laryngeal or oral trauma from the ET tube. And depending on certain factors, there have been cases of like broken teeth, or broken teeth, or teeth that have been, knocked out, or I guess teeth that were missing from the tube, especially if people have poor dentition. And that's really important to note if they have poor dentition, because sometimes you could even risk somebody choking on a tooth as the ET tube is taken out. So you want to watch for that. And then there is, we talked about the nerve trauma that can occur. So you do want to watch for that, and you do want to monitor for that as the patient is waking up. And there is that risk of burns, because we are working with cauterization, electric devices often, so you do want to be very careful for that as well. And there is always going to be a risk of cardiac arrest or death for a patient, especially with a very high risk patient or a high risk surgery. So is something to be aware of as well. So here's some sample nursing diagnoses. You can come up with a billion nursing diagnoses for the intraoperative, and most of them are going to be the risk for, obviously, because you're going to have a patient that is exposed. I mean, I don't even have risk for infection for the intraoperative, but obviously a patient that has an open wound is going to be risk for infection. But this is just a sample for you. And I think that's my last slide on here. Thank you.